any further ado, I would like to introduce Dr. Gupta to present to us the current COG approach in treating frontline pediatric acute lymphoblastic leukemia and the immunotherapy role. Dr. Gupta.
Thank you very much, Dr. El-Assid. It's a real honor to be offered the opportunity to present for the group here today. And even just on camera, I can see friends and colleagues, both current and past. It's nice to see everyone. So I will just share my slides here. Play from the start. So this is going to build nicely, I think, on Dr. Justania's talk that we just heard, which was outstanding as anticipated, but really just maybe taking a higher level as to where the COG is right now in terms of our treatment of childhood ALL and where we think we may be going in the next couple of years. So for the outline today, I'm going to start by talking just about the basics of COG backbones for treatment of ALL, which I think many are familiar with, so we'll do that pretty quickly. We'll then talk about identifying a subpopulation that achieves outstanding outcomes with minimal therapy. We'll talk about whether we can identify additional populations that have outstanding outcomes. And then finally, can we further improve outcomes in the remaining children? And if so, do we do that by intensifying traditional chemotherapy further, by using immunotherapy up front, or by using targeted or precision or small molecule therapy, whatever you want to call it? So in terms of the basics of COG backbones, so again, everyone in this audience is already going to know that all ALL protocols have induction, post-induction therapy that includes some form of intensification, and then maintenance. So this is a very basic graphic of standard versus high-risk therapy in the COG hands. And though all the protocols in high-income countries, are similar and get you at the same place in terms of overall event-free and overall survival, they all have subtle differences or not so subtle differences, and they all have different advantages and disadvantages unique to that protocol. That's the way I think of it anyways. So in COG, I think one of the main differences is how minimal the treatment is that our standard risk patients get. And Dr. Justania talked about 0932, but it's worth just comparing that standard risk therapy consists of a 3-drug induction, a very light standard consolidation, which is really just 6-MP, some LPs and a shot of vincristine. Intermaintenance 1, which is really just escalating methotrexate. Delayed intensification, some more escalating methotrexate, and then maintenance. On the other hand, children who are NCI high risk or who have high risk features at the end of their standard risk induction get moved over to high risk therapy, which you can see here, which is substantially more intensive, even more intensive than, say, BFM treatment, at least in terms of consolidation, for example. Again, just to drive the point home, comparing these two backbones, you can see here that if you are a child who gets COG standard risk therapy, you get a cumulative dose of 75 milligrams per meter squared of anthracycline, 1 gram of cyclophosphamide, and no high-dose methotrexate. And that does seem to make a little bit of a difference. This is a great study from the CCSS group that we're probably all familiar with that basically showed that contemporary standard risk therapy doesn't seem to be associated with risks of second malignancies or health-related mortality that were statistically different from the general US population. So for sure, these still are at risk of some late effects, but it seems to be actually quite minor, at least when we're talking about physical late effects. It's also associated with lower healthcare utilization. So a study we did here in Ontario looked at the risks of, emergency room visits or hospitalizations during specific phases of therapy. And what we found that was when you looked at our population-based cohort, pretty much 2/3 of patients were hospitalized at least once when receiving intensified consolidation, compared to only about 30% of patients receiving standard consolidation. So these are big differences. So with that sort of in mind as a background, despite that minimal therapy, can we identify a subpopulation of children with ALL that still has outstanding outcomes? And Dr. Justania kind of showed you that, yes, we can. So when we look at standard risk patients, the event-free survival is quite excellent, particularly for what we call the standard risk favorable subset. And the really simple way that I think of these kids is they have every good risk factor in the book, right? So they are NCI standard risk, they are CNS 1 or 2, they have favorable genetics by the COG definition, which isn't exactly the same as other definitions, but we say ETV6 RUNX1 or double trisomy 4 and 10. They have a day 8 peripheral blood MRD of less than 1%, and they are end of induction flow bone marrow MRD negative. And you can see here, sorry, this graph is for the overall population, but this standard risk population has a 5-year event-free survival of greater than 95%. And again, this is not a small number of children, right? This is over a third of NCI standard risk kids. So it's a fair chunk of the children that present to us with ALL every week. So in current COG trials, there is no randomized question for these patients. They do far too well to be able to ask a question, either maybe ethically or morally or statistically, frankly. So that's where we are right now. One of the questions, and I won't spend time on this because Dr. Stania did an excellent job of addressing this already, is can we identify additional subpopulations that have those same or similar outstanding outcomes? And this is where we really get into the potential, and I'll emphasize potential, role of high throughput sequencing based MRD. So this is the essentially exact slide that Dr. Stania showed you, which shows that, you know, among previously treated NCI standard risk patients who were end of flow negative, MRD negative, 20% also had no detectable HTS MRD at the same point. And the disease-free survival for these HTS undetectable patients, as we call them, was 98%, right? So just as good as the traditional standard risk favorable kids I was talking about just prior to this. So you'll see what I'm trying to do over this talk is just fit in sort of rationale for the current trials. And for our current NCI standard risk trial 1731, which I have the fortune of being co-chair with along with Dr. Rachel Rao in Houston, like I said, standard risk favorable, no randomized questions, standard therapy. For standard risk average patients, which are ones that don't meet standard risk favorable criteria, so they're not the best of the best, but they don't have any of the traditional adverse prognosticators we're all familiar with, flow MRD positivity, unfavorable cytogenetics, we are further risk stratifying those by their HTS MRD negative status. And if they are HTS MRD negative, then they just get standard therapy so that we can prospectively verify what we think is, based on that retrospective data, an outstanding outcome for this group. So again, when we talk about in COG, trying to identify further groups that have outstanding outcomes, one of the ways we're doing this is by betting on HTS and seeing whether that allows us to do that or not. So the big question, though, is can we further improve outcomes for the remaining children? And we really have 3 potential ways of doing that: further intensifying traditional chemotherapy, immunotherapy, or targeted therapy. So when we talk about traditional chemotherapy, I think it's worthwhile just having 2 quick slides about some positive versus negative trials in the recent COG history where we've tried to intensify or optimize traditional cytotoxic chemotherapy. So here you can see a list of trials where we did that and it worked, right? And you can see from the numbers that these are mainly 2-generation ago trials or 3-generation ago trials. And I won't go through the details here because I think many people are familiar, and Dr. Stania went through some of this as well. But here are a list of questions or trials in COG studies where we tried to intensify therapy, where we had negative results. And you can see that these are most of the trials that were in the last generation as well. So both in 2 generations ago in standard risk, trying to intensify consolidation or add pegosparaginase, or as Dr. Stania alluded to, intensifying consolidation further on 1131, these really haven't worked. So the sense that I think we and many other cooperative groups are coming across is that we have probably reached the limit in terms of what we can intensify and how much benefit we can get from further intensification for our patients. So then that leaves us with these 2 other strategies, the most exciting of which, as we all know, is probably right now immunotherapy. So currently, the strategy in COG ALL is to study whether incorporating immunotherapy into first-line therapy of B-ALL improves outcomes. And so what we've done is take each of the immunotherapies that we think are most exciting, and by their sort of side effect profile, slot them into different groups of ALL patients. Blinatumomab for standard risk, inotuzumab for high risk, and CAR T cells for very high risk. And we'll briefly touch on these and what I mean by that. So starting with standard risk and blinatumomab. So I think it's first important, because I've had to justify this, and we've all had to justify this to ourselves and others, why study a novel agent in standard risk B-ALL? After all, I just told you that most of these patients do actually quite well. So one reason is that despite the overall good outcome, because this is the most common subtype of ALL we see, half of all of our ALL relapses still occur among NCI standard risk patients. And as I alluded to before, intensifying traditional chemotherapy doesn't seem like it's going to work for this population. We tried more asparaginase, we tried to intensify consolidation, we tried a higher dose of methotrexate in maintenance, and none of these things resulted in a substantial improvement in outcome for NCI standard risk patients. So therefore, it really comes to further improvements are going to require probably novel agents. So we really have two choices. We can either say, we accept what the outcome is for these patients right now, and we don't think we can improve further, or we try a novel agent. And there are pros and cons to both of those strategies, but it probably is a little bit black and white like that. However, if we are going to try a novel agent, given the overall favorable outcome, that agent has to have both good evidence of anti-leukemia efficacy and also have a favorable toxicity profile. So we were lucky in that when we were coming up with this trial and coming up with a question, we did have an agent, blinatumomab, that sort of met those criteria. So again, we're probably all familiar, blinatumomab is a bispecific T-cell engager that targets CD19, which is found on virtually all B-ALL surfaces. There was encouraging initial results in the relapse refractory setting in both adults and children. Some of the references are there for you, but we're not going to spend time going through them. And then there were a series of trials that suggested that blinatumomab efficacy might be maximized through their use at earlier disease stages and lower levels of disease, and similarly showing evidence for efficacy of MRD clearance. So the BLAST trial was the quintessential New England Journal adult trial that showed that MRD clearance was something that blinatumomab was actually pretty good at. At the same time, as I mentioned before, it also has a generally favorable toxicity profile. We're probably all aware of cytokine release syndrome and neurotoxicity, but those tend to be pretty rare, particularly in patients who have low levels, and particularly MRD levels of disease when they are given their blinatumomab. These are really important results that I think we're all familiar with because they're a couple of years old now. But we did find in COG that in pediatric first relapse BAL, that patients with high risk relapse after receiving their initial reinduction chemotherapy, who were randomized to either receive 2 further courses of intensive chemo versus 2 courses of blina, did have superior overall survival, and on a one-sided test, disease-free survival as well. And our European colleagues showed the same thing, and these are 2 beautiful papers published side by side in JAMA, as you can see there. So this made us excited for blinatumomab in this context. So remember I told you that the standard risk average patients, if they're HTS negative, they just go and get regular therapy, no further question besides just making sure they do really well. The NCI standard risk patients who have higher risk features, either traditional ones like unfavorable cytogenetics or flow MRD positivity at the end of induction, or this potentially novel one like still being HTS MRD positive at the end of induction, they got randomized to standard therapy, whether that's standard risk or high risk backbone, versus standard therapy plus 2 intercalated courses of blinatumomab, as you can see here. I'm not going to spend much time on this, but high-risk Down syndrome patients, given their increased risk of toxicity, are non-randomly assigned to a backbone in which blinatumomab replaces some elements of standard chemotherapy, trying to take away some of their toxicity while maintaining or hopefully even improving their disease-free survival. We are not the only group, obviously, studying blinatumomab in newly diagnosed ALL. The BFM folks are, St. Jude's are, though generally in a higher risk population than we are in COG. Just really quickly, other considerations, there's quality of life that we're trying to measure that might be associated with continuous infusions, which we know blinatumomab is, obviously. There are cost considerations, particularly for those of us who practice in single-payer health systems. And since CD19 negative relapse is a known cause of treatment failure amongst patients receiving blinatumomab, and given the existence of other CD19 dependent therapies, we're really monitoring closely the incidence of CD19 negative relapse on our study. Okay, so that's blinatumomab. These other two we're going to go through in a more short form way. So inotuzumab in the context of high risk therapy. Again, I suspect we're all familiar with this. Inotuzumab is a humanized antibody against CD22. And that's taken into the cell, conjugated, it's conjugated, linked to calciumycin, which is cytotoxic to the cell. It's taken in and hydrolyzed, and then it does its job. Again, much like blinatumomab, inotuzumab has also recently, not so recently anymore, had good evidence in the relapse refractory setting in both adult settings, i.e. the Innovate trial, which I've referenced there, and in pediatric settings as well. Sinusoidal obstructive syndrome, that we used to call VOD or veno-occlusive disease, remains a significant concern. So that's why, given that concern of a maybe more significant toxicity profile, this was the agent that was chosen to take forward in 1732, which is for NCI high-risk patients, led by doctors Jennifer McNear and Maureen O'Brien. In this group, in this study, those who have high-risk favorable disease should have excellent outcomes. They're young kids who have favorable cytogenetics and are end of induction MRD negative. So those get siphoned off and just treated non-randomly with standard therapy. And everyone else gets randomized to standard therapy versus standard therapy plus 2 courses of intercalated inotuzumab. It has a safety phase, which has currently been completed, and we're just waiting for those data to come in, and then it'll be hopefully reactivated for an efficacy phase. Obviously, close monitoring of sinusoidal obstructive syndrome is going to be key on this study, and is key on this study already. And then finally, CAR T cells for our very high-risk population. So this is, Dr. Justaniev set me up really nicely for this in talking about what we know are the quite poor outcomes for NCI high-risk patients who remain flow MRD positive at the end of consolidation. You can see that 40% statistic that he put up as well. And so we're also all aware with how exciting CAR T cells have been over the last 5-10 years or so. So what 1721, led by Dr. Shannon Maud, attempts to do is see, instead of taking those NCI high-risk patients who are end of consolidation positive and sending them to transplant, which would have been standard, do we improve or maintain their outcomes if we send them to CAR T cells as well? So these patients, if they are end of induction MRD positive, then go on to screen if the parents and the physicians so choose for this study. And then if they remain positive in terms of flow MRD at the end of consolidation, then they actually are leukapheresed, manufactured CAR T cells, and then given CAR T cells. If you have a really high end of induction MRD, greater than 1%, we know you're probably going to be positive at the end of consolidation as well. So those patients we collect earlier. And that study is about halfway through its accrual, so it's accruing nicely, and hopefully we'll have answers in the not so distant future. Okay, so we talked about further intensification of traditional chemotherapy probably not working. We've talked now about immunotherapy, and then finally just a few short words on the role of targeted precision or small molecule therapy. And again, these are just examples. I know Dr. Biondi's already talked substantially about what's happening with pH positive ALL, and so there's further efforts there, and he and Dr. Tai Tran and Mignon Lo and many others are involved in an international collaborative trial of ABL class mutated newly diagnosed ALL. And then Dr. Sarah Tajian is very close to finishing accrual of AAL 1521, which is studying the addition of ruxolitinib to patients with newly diagnosed PH-like ALL, pardon me, that have JAK-STAT pathway mutations. So again, each of these is a talk in and of itself, but just to know that all of our eggs are not in the basket of immunotherapy alone, that there are these very exciting targeted therapies that continue to be studied both by ourselves and more often, given the rarity of these patients, now in collaboration between ourselves and our European colleagues. So in conclusion, we already know, even without immunotherapy and without targeted therapy, that we can identify a subpopulation of newly diagnosed children with ALL that has achieved outstanding outcomes with minimal therapy. New techniques such as high throughput sequencing measured MRD may help us identify additional populations with outstanding outcomes. Further improvements in outcome for the remainder of children are unlikely to result from further intensification of traditional chemotherapy. And the main current challenge for us is to determine how novel immunotherapy and targeted therapy can be best incorporated into standard therapy to maximize further improvements in the outcome. And international collaboration, as you've heard, I think, again and again, multiple times today, is going to become increasingly important, if it's not already, in achieving these goals. A massive number of people need to be thanked. Some of these slides belong to them, some are my own, but the work these slides describe is in huge part due to the people on this screen and dozens of others as well. And with that, I think there's a Q&A afterwards, not now. I may not be able to stay for that just because I'm still in clinic, unfortunately, and because we're running a little bit late, I might have to sneak back down to clinic. But
thank you so much, Dr. Gupta. Would you be able to take one question for us?
Of course, yes, I'd be happy to.
So we have a question that what do we do in a case of standard risk B-cell ALL, end of consolidation positive MRD or MRD between 0.01 and 0.1, no available clinical trial?
Yeah, that's an excellent question. I think Dr. Justania mentioned this a little bit. It is controversial. Dr. Justania mentioned Dr. Rao's paper in PBC that looked at the outcomes of these patients and actually was better than most of us would have anticipated, I think. Some caveats I'll put onto that paper, which the paper mentions as well. It's not like these are unknown. It's a small number of patients, so the confidence intervals are quite wide. And it's not as if these patients remained on a clinical trial, so we know exactly how they were treated, right? So some of these patients may have gone on to transplant, as many people were doing with end of consolidation positive patients in general, right? So we don't actually know what treatment they got afterwards, so it's really hard to make conclusions about that patient group. What I will say, and this is not based on evidence, is, you know, I often think of ALL as a score, right? Like you get good points and you get bad points, right? So the patient who is a 4-year-old whose MRD positive at the end of induction wasn't that bad, who has favorable genetics and is 0.02 at the end of consolidation, I'm probably going to think very differently about that kid than the 9-year-old who has IM21, who has end of consolidation 0.05, right, or 0.09. So, you know, is there evidence to guide exactly what you should do with either of those patients? No. But, you know, I think in the first one, I'd be a lot more willing to entertain chemotherapy only and watch and see how they do. Also know that we have these backups of immunotherapy in the relapse setting now as well, versus the latter one, I'd be a lot more hesitant about just going forward with chemotherapy as well. So I think we have a fair amount to learn still about that, that situation.
And thank you so much, Dr. Gupta, and we really enjoyed your talk. Thank you.
Thank you for the opportunity.